Hi, everyone. This is Podcast for Patients with the Aplastic Anemia and MDS International Foundation. I'm Leigh Clark, Patient Educator. Our podcast series is brought to you by the generous support of patients, families, and caregivers, and a special grant from Bristol Myers Squibb. Thank you, everyone, for supporting and joining the series today. We're today going to be talking with Dr. David Steensma regarding MDS and toxins. He is an associate professor at Harvard Medical School and faculty member in the leukemia program at the Dana-Farber Cancer Institute and Brigham and Women's Hospital in Boston, Massachusetts. He is also the Edward P. Evans Chair in MDS at Dana-Farber Cancer Institute. Welcome, Dr. Steensma, and thank you for joining us today.
Thank you, Leigh. Thank you for having me.
Great, thank you. Could you give just a brief description of what is MDS?
MDS is a term that refers to a group of bone marrow disorders that have several common features. Number one is they are bone marrow failure syndromes. That means that the bone marrow is ineffective at making blood cells. Secondly, they really are cancers. They are classified as such by the World Health Organization. They have mutations similar to leukemia, and a subset of patients, a minority, will progress over time to acute leukemia. And finally, they are also defined by marrow cells and blood cells that appear abnormal under the microscope. This is called dysplasia, and that's where the word myelodysplasia or myelodysplastic comes from. Myelo just means marrow, so it means the cells look abnormal when they are seen under the microscope.
Thank you. What are some of the known causes of MDS?
The biggest contributor to MDS is aging. The majority of people who are diagnosed with MDS are over age 50. The median age is in the early 70s. As we go through life, the stem cells, the seed cells in our bone marrow, accumulate DNA mutations just by random chance. And the majority of those mutations are inconsequential. We could detect them with DNA sequencing, but they don't affect the behavior of the stem cells. And so the majority of the population who are lucky enough not to get MDS, they never get a mutation in one of their stem cells that impairs its function. However, people with MDS just happen to have acquired a mutation in the stem cells, or a set of mutations in the DNA that causes stem cells to behave differently and no longer able to make healthy blood cells.
And thank you. What are some of the known toxins that can cause MDS?
Other than time, which is the biggest toxin because of the accumulation of errors in DNA that I mentioned, the best established are with chemotherapy and with radiation therapy. So people who undergo radiation therapy, especially to what's called the axial skeleton, which means the spine, the hips, and the skull, the central part of the body, are at some increased risk for getting MDS. Obviously, the majority of people who get radiation don't develop MDS, so there's an element of chance there as well, but it is a risk factor. Secondly, chemotherapy, and it's not every chemotherapy that can do this, but it's a large range of chemotherapy that are given for other diseases that can predispose to MDS. So a typical patient might be a woman who received chemotherapy for breast cancer 5 to 10 years ago, and she received radiation as well, perhaps. And then during routine monitoring, her oncologist notices her blood counts are lower than they had been, and evaluation shows MDS. So those are the best established. Now, in the older literature, patients would sometimes be exposed to benzene. There's not a lot of benzene out there that we get exposed to nowadays. It's very well contained in most industrial applications. Most places where benzene used to be used have been replaced by other safer materials, but you'll find that in textbooks as well. And the final one worth mentioning is cigarette smoking. There are all sorts of toxins in cigarette smoke, including a subset of chemicals that are called hydrocarbons. Those are similar to the ring in benzene, and they can be injurious to the stem cell as well. And studies of the population show that people who have a history of smoking have a higher likelihood of getting MDS than those who have never smoked. You know, the most people with MDS haven't smoked, but of those who have, there is a greater risk.
Thank you. Do toxins impact the progression of MDS if a patient is known, if their cause is known to a toxin?
So patients who have MDS that's related to toxin exposure often have a more rapid moving clinical course. What we term these as collectively as therapy-related MDS. It's thought to represent about 15 to 20% of MDS as a whole. And these patients tend to have a life expectancy that is not very long, usually less than 2 years, sometimes less than a year. And a lot of that is driven by the biology of therapy-related MDS. Many patients have a very complex chromosome breakage pattern, and the real danger is in those who have lost function of a gene called TP53. The TP53 gene is sometimes called the guardian of the genome, in that its job is to detect if mutations have occurred in the cell's DNA, and if so, to hold the cell from copying itself until that DNA damage can be repaired. If P53 is not working, if the cat's away, then the mice will play, so to speak, and the cell can continue to copy itself despite the DNA damage. And that turns out to be a very dangerous situation. MDS that arises out of the blue, so-called de novo MDS, can have a TP53 mutation, but it's much more common in therapy-related MDS. In fact, the majority of patients have TP53 mutations, and that's thought to account for the reason that they do worse. Interestingly, we have 2 copies of TP53 in our cells. Some people are born with only 1 functional copy. It's a syndrome called Leigh-Clark syndrome, and they often develop cancer in childhood or adolescence or in their 20s. It's a very dangerous syndrome. Many types of cancers, including MDS or leukemia, can arise in such a person. But elephants, they have such a big body, you would expect just by sheer number of cells that they would be getting cancers all the time, but they don't. And a large reason is because they have about 20 copies of the TP53 gene, and so they have a lot of police activity in their cells, shall we say.
Thank you. You launched the Agent Orange and MDS study at Dana-Farber in 2016. What were the findings?
Yes, this study, which was sponsored by AAMDS and by the Edward P. Evans Foundation, was meant to look at individuals who have developed MDS who had presumptive exposure to Agent Orange during the Vietnam conflict. And what we had hoped to look at was, do those individuals have some sort of molecular difference in their DNA compared to MDS as a whole? What I really would have liked to have done is to go back to the 1970s and check the blood of men and the small subset of women that were returning from Vietnam and from Agent Orange exposure there, and to look for DNA mutations then. Because what we've learned is that these mutations may take decades to accumulate. I can talk more about that in a minute, but the first mutations might have occurred in Vietnam. What we found was that by the time the MDS already develops, the MDS does not appear different from MDS in the population. as a whole. Similar sorts of mutations were seen. There wasn't anything unexpected. So MDS in veterans is like MDS generally. But we weren't able to definitively answer the question that I think we'd like to know, which is just what is the magnitude of risk elevation for veterans who were exposed to Agent Orange in 1968 or 1970 compared to the unexposed population. Because, you know, if you were 18 in 1968, you're 70 today, and 70 is the peak age for getting myelodysplastic syndromes just anyway. So if you get it now, we don't know, did it actually have anything to do with the Agent Orange exposure, or would it just have happened anyway? And unfortunately, we can't go back in time and you know, show the clear biological progression from one mutation to multiple mutations.
Dr. Steensma, are there toxins that people can be exposed to at work or maybe through hobbies that could be a cause of MDS?
Many people are exposed to potentially hazardous chemicals in their workplace environment. For instance, people who work on road crews or who pump gas in a gas station, they may be exposed to fumes from tar and from gasoline, and inhaling those could cause DNA injury. The difficulty is that, you know, many people are in those occupations and only a very tiny proportion ever get MDS, and those exposures tend to be at a very low level. And so it's often quite difficult to say whether an exposure from you know, glue from making ship models or tar from doing road work contributed to MDS. There has to be an element of chance as well. I'm often asked by patients because it's natural to want to look back and say, okay, this bad thing happened to me. Why did it happen? What was the cause? And people start to think, well, maybe it was something I ate or didn't eat, or maybe it was something I was exposed to in my environment or in my workplace, or some special hobby I do, you know, that maybe seems dirty, repairing cars or something. But we just, you know, we don't have the data, number one, to clearly make that connection. And number two, it's pretty rare for an individual, even who has heavy exposures, to be diagnosed with MDS. So there's clearly other things going on. And that doesn't mean that exposures don't matter. I mean, if you look, for instance, at individuals who were exposed to the atomic bombs in Nagasaki and Hiroshima, even 60 years later, 2005, after the event, they were still having an increased rate of MDS diagnoses compared to the general population who wasn't exposed in Japan. So, you know, there are exposures that may have happened many years ago that may be contributing, but it's just really hard to pin any of that down.
Does the type of toxin impact the treatment decisions?
Ironically, it really doesn't, and this is something that comes up with therapy-related MDS, where we say, okay, you know, chemotherapy caused your disease, and the best treatment for it is chemotherapy, and that seems paradoxical to a lot of patients, understandably. Number one, it's a different type of chemotherapy and less intense and has different biological activity, but there's the treatment is largely determined by the disease biology and presentation. That being said, you know, there may be genotype-specific things that are important in the future. For instance, TP53 mutations are targeted by a drug called APR-246 that's in a randomized clinical trial. In the interest of disclosure, that's a trial we're doing at our center. It's more than 30 centers are involved. I don't get any money from them or anything, but I should be transparent about that. That study is just finishing up, and we'll wait to see what the results are compared to people who got azacitidine or Vidasa. that'll be a treatment that helps for TP53 mutation MDS, where we really don't have super effective therapies right now.
Thank you. The Edward P. Evans Foundation created the Edward P. Evans Center for MDS at Dana-Farber. Could you tell us a little bit about the center and how that would impact for MDS patients?
Yeah, so a number of centers put in proposals to be an MDS center and receive special funding from the Evans Foundation. And 2 centers were selected, us at Dana-Farber, in conjunction with colleagues at Mass General and Boston Children's, and the Washington University in Lewis, where the leader of their MDS center is Matthew Walter. Ours in Boston is co-led by me clinically and by Benjamin Ebert on the bench research laboratory side. So this Edward P. Evans Center has 4 components. There's an endowment that will allow us to do some future research. There's some startup funding for some active research program. There is a small amount of money to bring in a couple of visiting speakers to meet with us and exchange ideas and collaborations each year. And then finally, some money to fund a special MDS fellow. And we've hired a very promising young investigator, Rahul Vejala, who had been a Dana-Farber fellow and a resident with us as well. And he's going to start on the faculty next month as part of our leukemia program.
Great. And if anyone was interested in finding out about any of the programs or trials, who would they reach out to?
So if people are interested in finding out what clinical trials are available, there's a couple ways that they can do that. The best is usually clinicaltrials.gov, which is a website. It's a national clearinghouse. So that way, if they're in California or Michigan, they can see what trials are available near them. Our Dana-Farber website has a list of trials and studies that are available at our center. And of course, we're happy to see patients in person or consult virtually. With the pandemic, we've moved a lot of our medicine to telemedicine. And a lot of our patients, we're doing remote consultations, so you can get our opinion without having to come to Boston. Of course, to participate in the study, you'd have to actually come to Boston to enroll and be treated. But if somebody just wants a consultation, we and many other centers are now doing those, many of those remotely. And I think that's here to stay.
Oh, well, thank you so much. Thank you, Dr. Steensma, for taking the time today to talk with us about MDS and toxins. And thank you, everyone, for listening. You can find out more about bone marrow failure disease on our website, aamds.org. You can also follow us on Facebook, Instagram, and Twitter, or by calling our helpline at 800-747-2820. Thank you.